Hi, everyone. For our final session on this track today, we're joined by Dr. Mamdani, who is the VP of Data Science and Advanced Analytics at Unity Health Toronto. And he'll explore the future of AI-driven healthcare and AI's broader potential across other industries as well. So the floor is yours, Dr. Mamdani.
Great. Thank you very much, Arun. I'm going to share my slides. All right. So people can see slides. Fantastic. All right. Thanks for the opportunity to present. A bit of background around me. I'm the director of the Temerty Center for AI Research and Education Medicine at the University of Toronto. But the role I'm going to be talking about more today is the VP of Data Science and Advanced Analytics at Unity Health Toronto. Our group basically develops and deploys AI solutions in the clinical practice. I have a clinical background myself. I don't practice anymore, but I also have a data science background and hold several positions, including faculty position at the University of Toronto. All right, the agenda here is to really give you a quick overview of where I'm from, which is Unity Health Toronto, give a quick overview of AI and its roles in healthcare, some of the challenges we've experienced in adopting AI, and then developing a health AI strategy, some things for you to think about. Briefly, where am I from? I'm from Unity Health Toronto. So Toronto's a city in Canada, and we've got a whole bunch of hospitals here. One of them I belong to. So Unity Health is a composition of 3 individual organizations that now have coalesced. The first is St. Michael's Hospital, which is in downtown Toronto. It's an academic hospital, so teaching hospital, level 1 trauma center, acute care, all the bells and whistles. On the west end, we have St. Joseph's, which is a busy community hospital. And on the east end, we have Providence Healthcare, which is a long-term care rehab facility. So I guess you could say we provide cradle to grave care, all sorts of services. We've got over 11,000 staff, and we have a lot of volumes, over 1.6 million ambulatory visits each year, 350,000 plus inpatient visits each year, and over 170,000 emergency department visits each year. We have about 15 years of historical data, which gives us enough data to work with around an AI program. The unique thing about Unity Health is that we are the only organization in Canada that has declared AI as a core strategic pillar. So we have 9 strategic pillars, 3 of them are core pillars, and one of them being AI, which means that from the board of directors to the CEO throughout the entire organization, AI is a priority for us. So we put resources into it. I have a dedicated data science team. We have about 30 people on our team. I have an annual operating budget of about $5 million a year. We've developed and deployed over 50 AI solutions so far, so we're fairly aggressive in this space. Many of the solutions actually are clinical in nature, and a lot of people are shying away from clinical. We go pretty aggressively on the clinical side. Why did we embrace AI? Because we're all tired. We're really tired of the healthcare system being stretched, of everyone telling us to do more with less. And we keep evolving. We don't need evolutions, we need revolutions. And this is why I think AI would be helpful. For those of us who actually talk about the healthcare system, who haven't really experienced the healthcare system, we have these grandiose notions of how incredibly amazing it is. When those of us who actually have experienced the healthcare system know that it's actually quite far from the expectation. That is the reality. That's me in the morning on the bottom. So why did we embrace it? Again, because I think we have this reality that needs help. The process of providing medical care is data-driven. If you think about it from a clinical perspective, if as a clinician are doing 3 core things, it's going to be to diagnose, prognose, and treat patients. And if we step back a little bit and say, all right, well, what does it take to make a diagnosis? What about prognosis and treatment? And how good are we at them? If you think about how we function as clinicians, everything we do is about data. So when we take out the stethoscope, listen to the heart rate, that's data going in here. The heart rate doesn't determine the diagnosis usually. It's one piece of information that goes up in your head. When we take a look at things like social history, family history, laboratory values, medical imaging results, signs and symptoms, all of those things are going on in our heads to make a diagnosis. And what we have to remember is that many diagnoses are simply opinions of an educated person. That's all they are. We have this magical notion that whenever you make a diagnosis, that's it. We're done. We're actually not. It's just an opinion. How do I say this? Well, if we look at common diagnoses, for example, there are many studies that actually are showing this now. Asthma, There's several studies that show that patients diagnosed with asthma, if you actually bring them in and do proper spirometry and lung function tests, only about a third of them actually have been misdiagnosed. They actually don't have asthma. Over 50% of patients diagnosed with schizophrenia actually don't have schizophrenia. So we need a bit of help. Prognosis, that drives how we actually manage our patients. Study after study after study has shown how poor we are at prognosis. We're just not very good at it. And treatment, well, there's lots of cases here. Things like multiple sclerosis, diseases like depression. We'll take depression as an example. How do we treat depression? The reality is that when we see a patient with depression, we typically have 15, 20 different drugs to choose from. Here's how we do it. These are the three that I'm really comfortable with, that I'm used to, that I've learned a lot about. And there's maybe a new one that the drug rep told me about 6 months ago. Those are the ones I'm sticking with. I'll try one. I'll call the patient back in 4 weeks. If they've done well, amazing, I look fantastic. If not, I'll try something else. This is how we practice. Obviously, we can do a lot better. Why is it that we're so poor? Well, it's because it's hard. A lot of these things are very hard. And people have actually studied how we make decisions. We've actually found, or studies have actually shown, that the average complex medical decision involves considering hundreds of parameters. In fact, a very complex medical decision considers about 1,000 parameters. Yet Miller, who's a famous psychologist from the 1950s, was able to show us that the average human can process 7 plus or minus 2 things at the same time. So of course we're going to struggle. How badly do we struggle? Well, there's a study that was conducted by the US Office of the Inspector General on Medicare patients. And what they found was that 1 out of 4 hospitalized patients will experience harm. 1 out of 4. 1 out of 8 patients will experience harm so significant that it'll result in a longer length of stay, result in permanent harm, or require life-saving intervention, or even result in death. 1 in 8. That's pretty significant. Now, they brought in a panel of experts and they said, so those numbers are pretty high. How many of these things could actually be prevented? The experts told them over 40% of patient harm, the cases they reviewed, were actually preventable. So yes, we struggle. It's all of this data that we have to process that makes our jobs difficult, the bureaucratic processes that are in place. There's a whole variety of reasons. But we do think that data and cognitive load are one of those contributors around poor performance. And this is where I think AI can come into play. There's so many roles for diagnosis, prognosis, and treatment where AI could help us. And I'll give you some examples of how. But first, I just want to briefly say, what is AI? AI has many definitions. One that's fairly common in the literature is any technique that enables machines to mimic human behavior. So any technique that enables machines to mimic human behavior. I personally think it's all about learning complex relationships in data. So how do you actually learn complex relationships in data? Machine learning is a subset of AI, which basically says, all right, historically we've had these traditional regression models, for example, for those of you who've been traumatized by your statistics courses, used to have a lot of liberty. So you'd be able to say, in my regression model, this is the dependent variable, these are the independent variables. I can actually play around with the beta coefficients or build in some correlations, look at interaction terms. There's a lot of control there. Now, machine learning says, you know what, leave all that up to me. Why don't you go sit down, have a coffee, human. I'll call you when I'm done, and I'll show you how magical my predictions are. I'm oversimplifying it, obviously. But basically, you give a lot more liberty to the machines. So what's deep learning? Deep learning is a subset of machine learning. Basically, it's just when there's more data and more complexity. That's all that deep learning is. And there's a bit of a vague line in between them. So we're using machines now to leverage our understanding, or to help us understand complex relationships in data. That's really what AI is about. How do we work? Our model is very simple. We want real solutions to real world problems. Einstein has a famous quote: if I had 1 hour to solve a problem, I'd spend 55 minutes understanding the problem and 5 minutes developing the solution. And we really, really adhere to that. We do not entertain questions from researchers. We do not entertain questions from data scientists. It has to come from the ground. It has to come from a clinician who sees patients every day, or an administrative decision maker who's really stressed out about the next decision they're going to make. It has to be from the ground. They come to us with problems, and any one of them can ask us, and then we go through an intake process. And we have several processes in our intake process where we actually ask them, well, what's the current state? Give me numbers, quantify the problem for me. Tell me how things would change if we actually built an AI solution for you. Outcomes. Let's focus on outcomes. We have 5 outcomes that we actually focus on. So there's actually a section on our intake form that actually says what outcomes are you going to impact, and you have choices. So it's not a free-for-all. Your choices are death, readmission, length of stay, human effort, and cost. Now there's a box that says other, and if you click other and that's the only box you click, you're automatically deprioritized. So we're focused on those 5 outcomes. And then we also ask you by how much. You've said that you're going to drop mortality 10%, 20%. We need a number. Because when you give us a number, that's what we're going to hold you to. We're also going to require you to be at every meeting. So for the next 6 to 12 months, every 2 weeks, you're in meetings with us. And if you can't make it, we don't take on the project. So there's incredible end user engagement. And it's a true co-creation model where people are engaged as we're creating a solution because we want to create something that works for them. We take into consideration things like human factors, machine learning operations, and such. Machine learning operations is very important for us. Some of our solutions, they're in the now. So you can't wait a day for data to come in. So you need data second by second. So we're heavy into things like data virtualization that really enable us to have real-time data feeds. And of course, deployment. We deploy them and we rigorously evaluate our solutions. We genuinely want to know if they work or don't work. Because if they don't work, why are we wasting resources trying to maintain these things? We should just sunset them and move on to the next one. Examples of projects that we've done or initiatives that we have. So these are not just employee projects, they're actually running right now as we speak. The first one is based on a patient that came to our hospital over a year ago. She had a really bad headache at home, nothing like she'd ever experienced before. And she said, I'm going to go to the emergency department. So she did. She went to a community hospital, and the community hospital said, it's just a bad headache. Why don't you go home? So she did. The headache starts getting worse. She has numbness down the arms. She goes to a second community hospital and says, look, this is like nothing I've ever experienced before. The emergency medicine physician orders a CT scan. So orders a head CT, and CT comes back. It must have been after hours. So the physician had a conversation with her and says, I can't really see anything. Why don't you go home? It's probably nothing. So she did. She starts blacking out. She gets rushed to the emergency department at our hospital, St. Michael's Hospital, and is rushed into the OR. The neurosurgeon operates on her. There were 3 infarcts or 3 dead spots in her brain. Luckily, she survived the procedure. Over 90% of people would die on the operating bed. She was left in a persistent vegetative state, though. You can imagine she was devastated. The family was devastated. The reality is that 1 in 10 to 1 in 20 bleeds are missed. They're simply missed. So if you have a bleed in your brain, 5 to 10% chance that your emergency department won't even pick it up. If you come to our hospital, in the emergency department, you're going to see this monitor that looks like you're at an airport. It's a big one that everyone can see in the clinician area. It circles through all of the patients in our emerge, where they're located, the emergency medicine physician who's looking after them, the medical imaging test they ordered, the radiologist who is looking after, and under status, every now and then, you're going to see the symbol that says ICH, intracerebral hemorrhage. Basically what that is it's our AI. Every single head CT is reviewed by our AI system, and in less than 2 minutes, it picks up a bleed. The same monitors in the radiology suite, and it pages our neurosurgical team so patients get care right away rather than wasting hours, because every second counts when you're losing brain function. We have an AI scribe. The AI scribes are getting more popular now. This was actually created, we first started on this in 2016 when nobody even heard of this. It was a family doctor who came to us and said, look, I'm really frustrated. I'm trying to get to talk to my patient, but I have to enter data into my electronic medical record. I'm distracted. When they leave, I know my notes are terrible. I have to fix them. It takes up way too much time. So can we actually create an AI solution that listens to my conversation with the patient, transcribes the entire conversation, and with the click of a button, it'll create my medical note for me? That's exactly what it does. So we actually created this solution. It became a startup called Mutual Health, and actually they were acquired recently, which is wonderful for them. The hospital actually has equity in the company, so we actually benefit from that as well. But the findings from an Ontario government study that actually was commissioned found that 3/4 of participants who actually used this solution actually reported reduced cognitive load. On average, 3 to 4 hours per week were freed up for direct patient care, and over 80% of participants said that they would actually want to continue using it. But this is all driven by AI. It just makes workload easier, makes their life easier, and it reduces cognitive load. Last example I'll give is around our internal medicine unit. Our internist came to us and said, we'd like to help people not die. And we said, that's great. And they said, could you predict who's going to die for us so we can actually act earlier because we think we can help them? So this solution is called ChartWatch. We have it up and running in our internal medicine unit. We've expanded it to our general surgery unit, and it's operating at St. Joseph's Hospital as well. What it does is it monitors our patients every hour on the hour. So every hour it's running, And again, we use data virtualization to be able to feed those hourly feeds. It typically considers between 150 to 170 different parameters, labs, demographics, vitals, and it predicts if somebody's going to die or go to the ICU in the next 48 hours. It's automated to page the medical team as soon as it reaches a high-risk threshold. Our protocols, the medical team has to come and see the patient within 1 hour of being paged. And there's all sorts of care pathways. Do you look for signs of sepsis, initiate antibiotics? Do you increase monitoring to every 1 hour, and so forth? We deployed this about 4 years ago, and we published our study in the Canadian Medical Association Journal just 2 months ago, documenting a 26% reduction in unexpected mortality. So these things are actually helping us save lives. And it's all driven by our clinicians, our administrative decision makers working with the data science team with the right MLOps technical environment to actually make all of this happen. We do have a responsible implementation of AI in health framework. We do a lot of clinical validation. We have ethical assessments. We actually have a Center for Medical Ethics that we actually consult with. We do bias assessments as well to make sure that it performs well in one subgroup versus another. We're really concerned about how it works at our hospital, so we're not so concerned about external validation, but as soon as we want to think about outside of our hospital, it becomes important. Explainability is a bit important for us, but not as important as people think, and I'm happy to get into that in the Q&A if people are interested on why I'm not so excited about explainability. Soft launches, we basically really, really rigorously test our solutions. So the last one that I showed you that predicts if somebody's going to die or go to the ICU, we spent almost a year in silent testing because we wanted to make sure the data pipelines were working, the model wasn't degrading over time, and so forth. So a lot of time spent on silent testing. And of course, evaluation. We really need to make sure that when we deploy these solutions, we're getting the outcomes we expect to see. Implementation and post-implementation, we spend a lot of time on communications. How do you use these tools? When are they working? When are they not working? How do you understand the limitations of these tools so you use them optimally rather than haphazardly, which I think could result in actually quite a lot of harm. So there's quite a bit of time we spend on communication. And of course, monitoring, evaluation, and maintenance. These solutions will be used, I hope, for many, many more years to come. The exciting part about creating these solutions is they're new, but what happens 4 years later? If something breaks at 2 a.m. and it's critical to the hospital, some of our solutions update every 15 seconds. We have a fairly large operations center. Who's going to fix it? Your IT folks won't have the expertise to do it. So our data scientists actually take call. They're on call 24/7. If something breaks at 2 a.m., they're up fixing it. It's that level of commitment that one needs to make these things work. There is a dark side of AI. This is why we have a responsible AI implementation framework, because there's a lot of challenges, from biases to model interpretability to all that sort of stuff. In the United States, there were some organizations that actually deployed algorithms that were able to direct care for certain patients. Unfortunately, they found that these algorithms were incredibly biased against Black people, and millions were affected. There's a gentleman in Belgium who committed suicide just last year. He was chatting with a chatbot that didn't have safety rails or guardrails around them. The chatbot's name was Eliza. The magazine wrote it up. Claire, who was Pierre's wife, whose name was also changed by the magazine, shared the text exchanges between him and Eliza with the magazine, showing a conversation that became increasingly confusing and harmful. The chatbot would tell Pierre that his wife and children are dead and wrote him comments that feigned jealousy and love, such as, "I feel that you love me more than her, and we will live together as one person in paradise." The chatbot even told Pierre that may be able to save the planet if you killed yourself. And so he did, which is rather unfortunate. And this is the sort of stuff we'd like to avoid and have more rigorous processes. Now, of course, there's growing interest in AI. Lots more publications. Number of publications we're seeing in the medical literature are growing exponentially to tens of thousands every year in virtually every aspect of medicine. The US FDA is approving more and more devices. As of August of this year, there were 950 machine learning or AI-enabled medical devices that were approved. This is growing exponentially as well. Why? Because there's a massive market here. The AI market, AI health market has been growing. Last year, it was estimated to be about $20 billion. It's expected to rise to over $500 billion in less than 10 years. So there's going to be a lot more activity in this space. But we have to be careful about the false promises of AI. Many of these solutions are not developed with a good problem understanding. They're not developed in a good testing environment. They're not even evaluated properly. So we have to make sure that these things are actually used in a responsible manner so they can benefit our patients. For those of you who are considering AI programs, think about where you are in the adoption curve. If you truly are innovators, you're going to require a lot of resources because you're going to have to pay for failures. Innovation, by definition, means that you are going to have failures. So you need a lot of infrastructure. You need to be able to create ML ops environments and such. If you say, no, you know what, I'm okay. I'm not going to be an innovator. At our institution, we decided to be both innovators and early adopters. But adoption is more about buying solutions and taking what other people have done. You don't need as much resource or infrastructure. So it's a little bit easier to become an adopter. And you can be a laggard and say, wait for everybody to fail, and then I'm going to pick the winners. That's the easiest way to do it. But then you won't really have these solutions as early as you ideally should to benefit your patients. So think about where you are on the adoption curve. In the interest of time, I was actually going to go through how we're structured, but and go through a sense of our 4 core teams. Our 4 teams are data integration, governance, advanced analytics, product development, product management, and deployment. And if you're an adopter, I would say focus on 2 teams, but also focus on AI literacy and AI governance. But happy to talk about that a little bit more in the Q&A if there's interest. And I'll just end there and make sure we have time for questions. Thank you. Oh, I think you're on mute, Arun. Arun, I think you're on mute.
Sorry. Thank you, Doc. That was fascinating. It was great to see how AI can be an extension of human clinical decision making by being able to process a lot more parameters than the human brain can. I would love to dive into the topic of explainability that you had brought up earlier. And you mentioned that that's not so important for you. My guess is part of the reason for that being, you know, clinicians are concerned with patient outcomes rather than explaining these algorithms. But what's your take on that?
Yeah, our experience has been that these algorithms are really good at really getting at complex relationships and data. And these are things that we have a hard time understanding. So it's a hard time communicating them as well. And the way we communicate these things are to oversimplify these drivers or these explainable factors. And you get to a point where it's so simply defined that it loses the essence of the machine learning algorithm to begin with. And it's incredible how once you actually start understanding that the AI actually performs well, you start trusting it and explainability becomes irrelevant. And there's a great analogy here, right? And we've seen this in clinical practice. The analogy is acetaminophen. How many people use Tylenol or acetaminophen? A lot of people do, right? And all the clinicians will say, oh yeah, of course I use it. And then when you ask the doctors, can you tell me the mechanism of action? Nobody knows. We don't know how it works. Not a single person on the planet can define the mechanism of action. Why do we use it if we can't explain it? Why is this any different?
Awesome. Yeah, that's really insightful. I would also like to ask you one final question here. How do you define and measure the success of AI deployment in a clinical setting?
Yeah, our definitions are a priori. So since the beginning, we've actually said those are the 5 things we focus on: death, readmission, length of stay, human effort, and cost. Those are the 5 things. So we're focused on those outcomes. If you have an idea that doesn't address those 5 outcomes, we probably won't take on the project. And then, of course, we use mixed methodology. We use fairly rigorous methods, observational epidemiology methods with sound statistical testing and such. I'm an academic myself, but we have academics that we work with that really, really rigorously evaluate it using cohort studies, matched analyses with propensity scores and such. So fairly sophisticated methods to make sure that we're actually doing it in a rigorous way to get the value and the outcomes that we expect to see.
Excellent. Well, thank you so much. Those are all the questions that we have time for today. Thank you so much for joining here. And thanks so much to the audience for tuning in as well.